Chair lays out House Bill 46. Chair lays out a complete committee substitute. Chair recognizes Chairman King to explain the bill.
Thank you, Mr. Chairman, members, for the opportunity to lay out House Bill 46. In 2015, Texas passed the Compassionate Use Act to allow patients with epilepsy to access low-THC cannabis. Since then, the program has expanded to include additional medical conditions, but many Texans still struggle to access the medicine they are legally allowed to receive. There are not enough dispensing organizations licensed in the state of Texas. The current law limits on how and where products can be stored and distributed. Inconsistent access, delays in licensing, and outdated rules around dispensing make it difficult for the program to meet the needs of patients. House Bill 46 seeks to address these issues while maintaining important safeguards. It requires the Department of Public Safety to issue 11 dispensing organization licenses with the goal of placing one in each public health region. It allows current license holders to open secure storage facilities with DPS approval without needing additional licenses. It ensures license holders begin dispensing within 24 months and continue serving patients after that. It updates prescribing limits to include a maximum 90-day supply with individual doses capped at 20 milligrams and a total maximum of 1.2 grams per patient at a time. It permits the use of inhalers when prescribed by a physician, offering patients more flexibility of how they take their medicine. The committee sub makes a change that allows a person with chronic pain to be included in the program if they would otherwise be prescribed an opioid. I believe this is a necessary step in battling the opioid crisis. Members, the Texans that access this program are not doing so to be intoxicated. They are seeking a natural alternative to prescription medicine. Expanding access to these patients will help many Texans, and I hope I would ask for your favorable consideration. With that, I will answer questions and respectfully I'd like the opportunity to close.
Okay, thank you. Any questions? Representative Frank.
Real quick, just to be clear, any of the THC usage in this is done through a prescription from a doctor, right?
That is correct.
So in some ways, to me, I always looked at this like really what we're doing is approving a certain type of drug to be used.
That's exactly right.
And that is significantly better than opioids.
Well, and Chairman Frank, I mean, you remember 2015 when we went down this road, it was for children with severe epilepsy.
Yep.
And that's why the program was created. And really the problem is the program was set up, but it's never been made functional or accessible. I mean, there's 2.5 licenses in the state of Texas today, and there's certainly none that serve your region or mine.
Right. Okay. Thank you. Thank you, Jim.
Okay. Okay, we will reserve your right to close.
Thank you, sir.
We're going to take public testimony. Chair calls Karen Reeves, Marcus Rourke, Matthew Brimberry, and Heather Fazio. Well, we have 25 people on the list. You're kidding. No. We'll get to you. Yes, ma'am. Okay, I have Karen Reeves testifying on behalf of Syntex Community Outreach and yourself. You're testifying for House Bill 46. Is that correct?
Yes, that's correct.
Thank you.
My name is Karen Reeves. I'm here to represent myself in the Syntex Community Outreach, testifying in support of HB 46. I've been a cannabis consumer for about 50 years and an activist for the last 13 years. This is my 6th legislative session to come and participate in. I am also a TCUP patient. I qualified for the TCUP for 2 conditions. One for incurable neurodegenerative disease and PTSD. And I became a TCUP patient in 2021. Unfortunately, the medicine is too expensive and does not work for me. And I know I'm not the only one. Testifying is not as easy as it looks, and so many Texans cannot make it to the Capitol today. So I'm here to stand up for those that cannot stand up for themselves or make it to the Capitol. We are not criminals, and Texans deserve medical freedom to choose a safer alternative instead of taking harmful medications that our bodies do not need. And in that regard, I do support expanding the TCUP to include more satellite locations, more dispensaries. I also include, if we, in the future, reduce the prices of these products. And I hope that the delivery methods would include the topicals and the lotions, things like that. But unfortunately, edibles do not work for me. My body does not break down the THC in my liver, and maybe a doctor can explain why that happens. And I think that it happens to a lot of people. So edibles are not effective for me. And I know I'm not the only one. Thousands of Texans can qualify for TCUP, but are intimidated by the process. We need more options. Getting the recommendations to use the TCUP is also a daunting task. It can be expensive going back and forth to the doctor to get the renewals necessary for every year on these fixed incomes. So in conclusion, for our personal health and wellness, the TCUP can really benefit a lot of people. But for me, I have to get my cannabis on the black market. I use cannabis flower. I only really use about 1 gram a day. I microdose through the day. Now, I have chronic pain. I have a long list of illnesses that cannabis has helped me for the past 50 years. When I was a teenager, I used cannabis and didn't even realize that it was helping me get through the hard times of not fitting in. And so I've experienced a lot of trauma and a lot of bad things because of prohibition. And this TCUP bill is a good step forward, and I'm hoping y'all push it through as quickly as possible. Thank you.
Thank you. Thank you for your testimony.
And I'm open to questions too, you guys.
We'll come back to questions. We're going to take all 3 testimony and then open for questions. Marcus Rourke, former President Good Blend, testifying on behalf of self, and you are for House Bill 46. Is that correct?
Yes, I am.
Okay, proceed.
Good evening. Thank you, Mr. Chairman and members. My name is Marcus Ruark, and I am testifying on behalf of myself in favor of House Bill 46. I would like to thank Representative King for filing this bill. I was the president of Good Blend, Texas, one of the current active licenses from 2017 to 2021, where I was responsible for standing up and managing Texas CUP operations. Additionally, I was the global head of research and development from 2018 to 2020 for Good Blend's parent company, Parallel. I'm no longer active in the Texas program, but wanted to share some learnings from when the program started and evolved to where it is today. Patient access is the most critical challenge. The Texas CUP statute specifically says DPS must ensure reasonable statewide access to the program. That is not easy to do in a state as large as Texas. DPS is a great partner to the program, and from my experience, was always responsive and willing to listen to our point of view whenever we had an issue. DPS recently hired a consultant to provide recommendations for the program, and they specifically recommended significantly increasing the number of regulated licenses. From my experience, the limited number of licenses is far and away the most pressing issue that has restricted patient access in Texas and has driven seniors, kids, and veterans to seek unregulated products. States of our size typically have a minimum of 15 or more licenses. For example, Florida, which has a very successful medical program, commenced its medical cannabis program with 22 licenses. The expansion of licenses would also reduce costs for patients. A medical grade product is much more costly to produce than the unregulated gas station hemp products patients are now accessing. With absolutely no competition, in reality only 2 companies currently operate in Texas, there is no competition nor pressure on pricing, and adding more licenses will increase competition. Additionally, a significant increase in licenses will generate significant investment in the CUP, including investment in patient education and increased patient awareness of the CUP. Finally, in conjunction with HB 28, patients that need THC as medicine will come into the CUP, and the CUP must expand to be able to accommodate these new patients. Also important to providing patients with effective medicine are adjustments to product requirements, including dosage and formulation updates. Thankfully, HB 46 addresses these issues. However, I strongly recommend that the licensing language be changed to ensure that there are sufficient licenses and locations in relation to population density
Mr. Rourke,
rather
can you
than
wrap
just
up,
public
please?
health regions. Treating major metropolitan areas the same as rural areas will limit patient access in our major cities. In sum, Texas needs more licenses to provide Texas patients with the medicine they need. Thank you, and I'm happy to answer any questions.
Thank you for your testimony. Chair recognizes Dr. Matthew Brimberry, testifying on behalf of self for House Bill 46. Is that correct?
Yes, sir.
Thank you.
Thank you, Chairman Van Dever and the members of the Public Health Committee. I'm here in support of House Bill 46. I'd like to say three things if possible. First thing is we should allow the medical doctors the diagnosis for the patients in order to get into the TCUP program. As I'm reading the latest rendition of the bill, it says, any condition that causes chronic pain, which a physician would otherwise prescribe an opioid. Well, we have good evidence that there's other diagnoses out there that patients should be able to access this program, such as fibromyalgia and inflammatory bowel disease, that we would not consider prescribing an opioid. We should not be limiting those patients. I think that language should be struck, and instead we should put any condition a physician determines would benefit, the benefits would outweigh the risks of the patient having access to the program. Additionally, if we look at other states that have these programs, when they put in chronic pain, it's a catch-all. And if we're looking into the future and trying to figure out which conditions actually are going to be better and which patients keep coming back, we would want to have those physicians be able to put in the specific conditions so we can follow that data in the future. Second thing, when they're saying that a 90-day prescription needs to be renewed, the standard of care in other states is 1 year. Patients get 1 year worth of medicine, and a physician will write a card, goes in the mail, and they're not able to get it back. We're unique here in the state of Texas. As the physicians qualify these patients, we calculate the amount of dose that they need, and let's just, as an example, I'll take the woman next to me. 1 gram of flour equals about 40 milligrams of THC equivalents if they can metabolize it. 40 milligrams a day, 30 days in a month, that's a 1.2 grams, so 1,200 grams times 12 months, 14,400 milligrams a year. We could put that into the cup and follow our patients, and at any time we decide that they should have their medication rejected, we can stop that. So I'd like to expand on that if given time.
Okay, thank you for your testimony. Heather Fazio. Okay, let's show Heather Fazio as registered but not testifying. Members, questions for this panel? Okay, no questions. Okay, thank you for your testimony. Is that the order?
Yes.
Okay. Chair calls Piper Lindeen, Louis Lux, Nico Richardson, and LaTanya Whittington.
Sorry about the interruption.
I'm sorry?
Chair and body, I'm sorry about the interruption.
No. Thank you. Thank you. Okay, I have Piper Lindeen testifying on behalf of Americans for Safe Access and Self. Sure. And you are testifying for House Bill 46, is that correct?
Yes.
Okay, you may proceed.
Okay, thank you, Representative King, for introducing the
Please,
bill.
please use the microphone.
Thank you, Representative King, for introducing the bill and for this opportunity to speak. Thank you for the committee for hearing this today. My name is Piper Lindeen. I'm the mother of a child with severe seizure disorder who is Texas's second and longest TCUP patient. To help my son survive and thrive, I need access to every possible tool, whether it's through TCUP or over-the-counter hemp products. I support HB 46 with additional expansions that haven't yet been included. Patients need broader access to medical cannabis. Anyone who can benefit from it should be able to participate in TCUP. This includes people with autoimmune, inflammatory diseases, chronic pain, and rare conditions. Even better, let doctors decide. They're the ones who know their patients best. They're the ones who have access to clinical research that shows. We also need access to a wider range of cannabis cultivars and many more cultivators. The entourage effect, the way cannabis molecules work together, is critical for effectiveness. Isolates don't cut it. We need full spectrum options. Full spectrum is not prohibited by law, but it is by policy and limited by license caps. Delivery methods matter too. Not all patients can ingest cannabis, especially those with feeding tubes or behavioral challenges. Inhalation, especially dry herb vaporization, is the safest and most effective route of administration and also creates different active metabolites from ingestion. HB 46 would allow inhalation, which is a vast improvement. We also need good manufacturing products so that we know our medicine is safe, consistent, and accurately labeled. Testing that includes full panel profiles and contaminant testing available for patients on a certificate of analysis. On top of that, patients need a real voice in regulation. Current unwritten policies like banning overnight storage and limiting to isolates create real barriers for patients who already have very difficult lives. Finally, we need educated providers and better research. We should encourage CUP patients to use dose and results tracking software, which will be compiled into a database which providers can use to guide cannabis care. Texas has the chance to be a national leader in cannabis medicine, but only if we support real access and real science. Thank you again for your time in considering the real needs of patients like my sons. And then I also want to add that because I needed to do the best for my son, cannabis medication for him was difficult. The first thing that we tried was fantastic, a dream come true. And then we learned the entourage effect through trying different things that didn't work. And we had to go through this process, trial and error. And so I pursued a master's degree in medical cannabis science and therapeutics at the University of Maryland School of Pharmacy. And I consider myself an expert in a lot of aspects of cannabis.
Okay, thank you for your testimony.
Welcome any questions.
Okay, Chair recognizes Lewis Lux. Is it okay? Show Lewis Lux is registered but not testifying. Chair recognizes Nico Richardson, CEO of Texas Original Compassionate Cultivation and Self, testifying for House Bill 46. Is that correct?
That's correct.
Thank you.
Thank you, Chairman Mendeever. And thank you, Chairman King, for introducing the bill. Members of the House Committee on Public Health, my name is Nico Richardson, and I'm the CEO of Texas Original Compassionate Cultivation. I'm testifying in favor of HB 46. Compassionate cultivation is the largest license in the CUP. We're about 65% market share, so we serve the majority of the patients in Texas today under the CUP. We've invested heavily to build out a compliant distribution network within this program, within this state. Despite this, there are limitations in the current program today that make the medication very difficult for our patients to access. As a result of these limitations, we've seen a fairly large number of patients end up leaving the CUP for non-medical forms of cannabis, either in the gray market or black market, so hemp market or black market. There are three primary reasons that we see patients leave the CUP. The first is access, the second is price, and the third is the lack of inhalable products within the CUP. Improvements in HB 46 will greatly reduce these barriers and make the CUP a viable program for patients in Texas. Right now, we may only store our medicine in a single location in Texas. So earlier you heard about issuing 11 licenses. That we think that's a good improvement to the program. But even today, If you had 11 licenses and you forced them to keep all their inventory in one location, you wouldn't be able to have reasonable access across Texas. You have to be able to carry your inventory off-site in satellite locations, which HB 46 does allow, which is great. That means in order to serve patients outside of Austin, our location's in Manchac right now, and we're moving to Bastrop. Our drivers must travel from our facility to pick up locations across Texas every single day. If a patient doesn't pick up that medication from their pickup location on a given day, we have to drive it back to Austin, reschedule for that patient for another day that week, the following week, the next week. This adds exorbitant costs to the system and wait times to deliver medicine. So really, it's two issues in one, accessibility and price that it adds to. DPS approved satellite locations will help solve that. The last is inhalable forms of medication that are currently not available in the cup. Many of our patients leave the program to access these products in the gray and black markets.
Thank you, Mr. Richardson. Can you wrap it up, please?
Yes, of course. We're strongly in favor of HB 46.
Thank you.
Happy to be a resource for any questions you have.
Thank you. Chair recognizes LaTanya Whittington, founder of Cannabis Reform of Houston, testifying on behalf of Cannabis Reform of Houston and self, and you're testifying for House Bill 46. Is that correct?
Excuse me. Yes, that is correct. Again, my name is LaTanya Whittington from Houston, Texas, and I'm founder of the Cannabis Reform of Houston and Texas. I was diagnosed with trigeminal neuralgia in 2017. That is not on the TCUP program. As you see, these are the medicines that I had to take. It's killing me. It's a chronic pain disorder from a damaged nerve on the right side of my face. I had a tooth pull. The nerve was attached to the tooth. Electric shocks from my face to my brain. Episodes touching my face. Light breeze, smiling, breathing, touching my face with makeup and more. Spontaneous attacks with no more warning is scary. I had a microvascular decompression surgery in 2019 through my skull, inserting a Teflon on my seventh nerve. Cannabis saved my life. It helped me. It took 8 months for me to recover from such a bad surgery, severe. With House Bill 46, I will be able to receive a medical card for my debilitating ailment. This is a condition that causes chronic pain from which a physician prescribes opioids. A medical condition with debilitating medical pain. I am disabled by the state of Texas. My debilitating and chronic pain should be designated for a physician to prescribe me cannabis under this bill instead of taking all of these medications. Look at this. My condition, my PCP, only a neurologist can prescribe me opioids for relief. I'm tired of this. I received SSI disability designated by the state of Texas. So I do apply for this bill. I have a disability, medical condition. I should be able to obtain from a medical condition a medical card.
Ms. Whittington,
This
can
is
you
the
can you wrap
perfect
up,
bill
please?
for me.
Thank you.
My last statement, cannabis should be placed on a ballot for the people to vote. We are adults, let us make our own decisions, not with the stinking thinking, not your personal feelings. We know what's best for us. It's not a narcotic.
Thank
It
you,
is
Ms.
a
Whittington.
plant. Free the weed in Texas.
Thank you for your testimony. Members, any questions of this panel? Representative Cunningham.
Thank you, Mr. Chairman. Mr. Richardson, you
Yes,
had
sir.
mentioned something about satellites, so I'm kind of curious about that. I've got a couple of questions. But I want to go back to, you mentioned the law. The law now, as it stands, is the language in the law adequate to allow for, the licenses to quickly, be established and operated?
Yes, in the HB 46, it allows for us to, as long as the DPS approves, it'll allow us to carry inventory at off-site locations. The one thing I would like to say about the law that I noticed in the most recent version, you want 11 full licenses, one for each region in the state. You currently have 3 licenses in one region. So we can manufacture in that region and be able to immediately distribute to the other 11 regions, which is what we do right now in Texas. My only concern is if you try and redistribute those 3 licenses tomorrow when you pass this bill, what are you going to do with 2 out of the 3 of them? You're going to force them to close their doors and move them to another location? Just something that we probably need to think about here.
Okay, so with the satellites now, I guess, well, how do you store it then? How does the storage work?
Yeah, we have to store them in a secure location in our one facility, which is in Manchac. So we have basically steel cages or gun vaults is essentially what the initial version of the bill called for. Large vaults, steel vaults in our main distribution facility. And so we will take that medicine out of the vaults or the steel cages. We put it into our distribution cars. We'll drive that across the state of Texas. If a patient is not there for delivery in El Paso or Rio Grande Valley or East Texas, we have to drive it back that day as soon as possible and put it back into storage in that one facility.
So with the proposed 11 then, will that make it more accessible?
Actually, the 11 doesn't change accessibility
doesn't?
immediately.
Okay.
It's the satellite locations that allow us to, and that's separate from the 11 licenses language. Each of those licenses is able to now carry inventory at satellite locations off-site. So we have about 14 locations right now that we drop medicine off to and bring it back, but we can't keep medicine there in a vault under, lock and key with security.
Okay, well, I guess I got confused because right now you currently have 3 in one.
There are 3 licenses right now, and then we have something that the DPS set up called TDS, which is a temporary dispensing site. For each one of those licenses, they have multiple TDS locations. So think of it like a CVS or a Walgreens, but I can't keep anything there. I can just drive it there every morning, have patients pick it up, and if they don't pick it up, I have to drive it back immediately that day.
Okay, and one last question. There was a group up earlier, and I forgot to ask the question, but they mentioned something about dosage, and they made a year. What is the average dosage?
Yeah, our average dosage today, basically 2/3 of our patients receive somewhere between 60 and 80 milligrams of THC or less per day. About 8 to 9% receive 100 milligrams or up a day, where their prescriptions currently lie, as it is.
Okay, and well, I said one more question. 65%.
Yeah.
What does that number equate to? What is 65%?
So we probably have somewhere in the TCUP in general probably has between 20 and 25,000 active patients today. We don't know the exact number. DPS does not report on that. We know that there's been about 105 patients that have ever signed up for a TCUP registration.
Okay. Thank you, sir. Thank you, Mr. Chairman.
Representative, go ahead.
Satellite locations? Can I?
It was for everybody.
Okay, so the thing is, for patients, the lack of satellite locations is a huge barrier. We have very limited time frames and number of days a week where we can pick up medication. So if we were to order medication, say, usually it's in the middle of the day, lunchtime. I work in clinical practice, so I can't pick up. Luckily, my husband here works from home and is able to go and pick that up. But if he wasn't, it would be very difficult. But if my son has a seizure right before the scheduled pickup time, which is typically a 3-hour window in the middle of the week, then we can't pick up his medication and he may miss his medication. And it's also, because it's a liquid, it's really difficult to gauge how much dosage is left there. So there's a lot of times where, and he stays with his grandparents, things like that, comes home and it's like, oh my gosh, we need to order medication and get it tomorrow. And that doesn't happen because there's no satellite locations.
Thank you. Representative Collier.
No, my question's for Dr. Brenda.
Okay.
Some tissue, please.
Any other?
Sure, sorry.
Thank you.
I need to read him back. Okay. Representative Collier.
I'm sorry, it's just been sitting heavy on me since he wanted to finish and we didn't give him that chance to finish your testimony. You said you had one last thing you wanted to tell us.
Yes, ma'am. I was in the middle of talking about how the new bill is saying something about 90 days of your prescription. Our standard here is writing a prescription for a year. This is going to be an extra layer of bureaucracy that is going to affect our patients. And unfortunately, I'm afraid that clinics may think that this means that they need to see patients every 3 months. The program's already expensive. If we could write the law to where we have a year's worth of certification, the physicians will still have the ability to cut a patient off if they see any diversions of medicine, which, by the way, I have not seen in my practice. The three people that come to mind, and they do affect folks in your district, the Houston Fire Department. We have firefighters that come to us, and they were at a previous clinic where they were having to have their certification uploaded to HR every 3 months. This medicine stays in your body for more than 2 or 3 weeks, and so if they missed a day and got a urinalysis, these first responders could have been terminated. We also have a lot of patients in nursing homes, and I can't explain to you how difficult it is when you have a caregiver of somebody who doesn't have capacity, and you're trying to reach out to them on the telephone to coordinate a visit to get somebody certified. To have to do that 4 times a year, I can't imagine that. So if we could, right now the TCUP doesn't have a limit on when you need to see a patient, but the standard is we should at least put that at 1 year. If a physician decides to see their patient every 2 weeks, God bless them, because they may need it. But we shouldn't limit it to 3 months. That's going to be way too bureaucratic.
Thank you.
Okay, any other questions for this panel?
Add to that very quickly is it's also incredibly expensive for the patient right now because health insurance doesn't cover the cost of the doctor's visit or the medicine. And so if you increase the doctor's visits by 3 to 4x a year, you get escalating pricing. Sorry.
Okay.
Thank you. That's a good point.
Representative Jones.
I've got a question about, so right now there's, I think you said, Mr. Richardson, that you guys have 65% of the,
Yes, that's correct.
so with these other, however many more that they're gonna add, like how do you get the license? I mean, it seems like they'd be hard to get, there aren't that many. So this, would you say that you guys have a monopoly or?
If we have a monopoly, this might be the least profitable monopoly in the history of monopolies. So I wouldn't call it that. Right now, the current law, not HB 46, the current law allows for 12 licenses. And so the DPS took applications for licenses and then has not issued them yet. But that is current law. So it's really a regulatory process to issue those licenses. I can't comment on why they have or haven't.
So you have 65% of some non-existent licenses? Is that what you're saying? But at some point,
we serve 65% of the patients in the market today, primarily because we invested a very large sum of money in order to build out a facility that could do that. No one else did. So we built ahead of a market that never really materialized.
Also, the whole thing, if you build it, they will come, that didn't work for you?
Well, we built it and then hemp came.
Okay. So, but was it you who made mention of the 3 licenses in an area, in a region? Was that?
So, yeah, right now, I don't know the exact health regions that they were referring to, but all 3 licenses are centrally located in Texas today because that's where 80% of the population is. And so they're centrally located there. That's where any license is going to have most of their patients in those regions. What they're going to be able to serve the other regions most effectively through satellite locations. So you manufacture in one location, you distribute out in a hub and spoke model and keep your inventory or keep your medicine in Rio Grande Valley, in Lubbock, in East Texas, in South and West Texas, but you you can still manufacture in one location and then distribute and hold your inventory in other places, which is really how every other industry works, right? If you're Pfizer and you're creating medicine, you don't keep it all in one plant and then ship it back if people don't pick it up. You keep it at CVS and Walgreens across the country under lock and key.
Okay, thank you.
Representative Collier.
Thank you. Ms. Whittington?
Yes, Whittington.
Whittington, your state representative is advocating for you right now, Penny Morales, and I'm asking you a question. And I want to know if you could tell us how this particular bill, if this is passed, how that would help you alleviate from this medication.
Absolutely. I have 3 opioids here. I'm taking tramadol. I'm taking hydrocodone, oxycodone, and clonazepam. Nausea, Zofran. Cannabis can help me with my nausea, with my anxiety and depression that I have dealing with this debilitating pain. It could help take me off of tramadol and also detox me off the hydrocodone and the oxycodone. This disease that I have, trigeminal neuralgia, is non-curable. I will have to live with this for the rest of my life. Oh. As I said, talking is one of my triggers. So I just had an episode at the time. I have to go to the hospital at least 2 times at a total month. This time I'm having an episode for about 2 or 3 months now. Sometimes it takes a stop while I'm okay, and then it comes back spontaneously with no warning. As I said, I had the microvascular decompression surgery, in which the neurologist told me that there's nothing else that she can do for me, that I have to take these medications. And it's killing my liver, and it's killing me. If I can get concentrate and also the correct flour that's going to help me, then I'm better. Because when we're getting off the streets, sometimes I can get the right kind, sometimes I can't. Let's be reasonable here. Look at what I'm suffering with. And then what I need is a doctor to prescribe me the right cannabis or the right concentrate oil that will take me off at least a few of these medicines. They don't know what to do with me. Some of these are seizure medicines. I do not have seizures, okay? But when I'm in episodes, I twitch like this because of the pain. Ah! This is what I go through. Scream. So they don't know what to do with me. There's one more procedure that can be done, and it's called a gamma knife, okay? It has knife at the end, but they don't actually use a knife, and this is it. Nothing else they can do for me.
And so
they
that
use a
medicine will help.
ray, they burn the nerve, right? And then, yeah, it has to be a neurologist and a radiologist, neurosurgery, and a radiologist to do this procedure. And I'm very scared. They said it might take 6 months to even feel some type of relief from it, you know. So I'm like, should I do this or should not? I have a husband and daughter to live for. And they deal with me every day feeling sad and wishing that they could do something to help me. I know that I deter, but this is my life. And I wanted to show y'all what I came to talk about me, my life, and how I want Texas to help me. I don't apply for the TCUP. Trigeminal neuralgia is not listed. So I cannot get a medical card. I'm sure none of you guys has heard of trigeminal neuralgia. And yes, you heard me testify. That's why I gave everyone information so that you can read up on it and see the debilitating pain. Now, I do have debilitating pain. If we can get this bill passed, it doesn't matter that trigeminal neuralgia is not listed on the Compassionate Act. I will be able to have it because I have the symptoms that is on this bill. Chronic pain,
Right.
debilitating pain, disabled by the state of Texas, on opioids, okay? Everything would be check, check, check. And then maybe I'll feel better and be a better person. I'm always sick.
Understood. Thank you so much for sharing your story and your personal experiences. It's very helpful as we make decisions. Thank you.
Thank you.
Is it possible to add on to what she said a little bit?
Take the mic.
Is it possible to add on to what she said a little bit? I think like it deserves more explanation, how she said her particular medicine. So my son is the same way. My son started, we started cannabis with him because we were told that he wasn't going to be able to speak anymore. And so the first thing I tried on him was a homemade tincture from Black Market Cannabis that worked perfectly. He had 6 weeks of seizure freedom. He was able to be his normal self again the next day, and it was wonderful. But then I got some more Black Market Cannabis, and it didn't work quite as well. And then the next thing I tried didn't work quite as well either. And so then, this was 11, 12 years ago, but I reached out to people and was advised that there are these different molecules in cannabis that contribute to what is called, and clinically, there's clinical recognition of this entourage effect. And for different patients, different conditions, the different patients, we all have this system that interacts with cannabinoids. It's called the endocannabinoid system.
Yes.
We make our own cannabinoids that interact with it. And everybody's endocannabinoid system is different. And so we need access to all of these different naturally occurring chemotypes or chemical fingerprints that are in cannabis to be able to say this is going to be the one that works for me. And also one of the things that I talked about in my testimony is we need to be tracking that as a state, that where we can say, you know, my son has Lennox-Gastaut syndrome. It's really difficult. It's a lot like Dravet. Charlotte Figi had Dravet. They're very similar disorders. It's characterized by regression to age 3 to 5, early death.
Yes.
A lot of difficult things, and you know, cannabis has just been like an incredible hope for my son. But the thing is, we still struggle because we don't have access to that wide variety of chemical fingerprints that we need. We need everything that we can get access to, and we need to be tracking it not now, not 2 years from now. We need to be tracking it 20 years ago. This is ridiculous that this stigma has kept us from researching this and understanding how to do this. Cannabis kills cancer. Cannabis treats type 1 diabetes. It's incredible. We have someone here from the Technion Institute in Israel where they're researching incredible things with cannabis. And yet we do, what do we do here in the United States? We just blackball it, all of it. We can't study it. We can't understand it. So families like ours, families like all of these who you saw at SB3 and HB 28 hearings, we suffer. Your families, no doubt, have people who suffer because we don't know how to use cannabis. And we need to start learning. And Texas can lead the way in that. We have the biggest medical center in the world, and we should be tracking this. We should take this opportunity to start a database and help guide practitioners to say, your child has Lennox-Gastaut. We see all the other people who participate in Texas Compassionate Use Program can benefit from this chemotype.
Thank you.
Thank you. I'm
Thank you,
sorry.
Chairman.
Thank you. Representative Johnson.
Thank you so much. We're all going on 14, almost in a half hours. We have a whole bunch of people that still want to be heard, and we are all hearing you and appreciate it very much. Ms. Whittington, thank you for always coming up. You always do. This is directed towards Mr. Richardson. You mentioned earlier you had people in teacup. They left. They went to the black market. Can you please answer the question about what you all manufacture and the fact that you actually know what you're producing and what people are consuming?
Yeah, and that's the biggest difference between, we understand why people have to sometimes leave, go into the black market to find products
You
that aren't
gotta talk
available.
into that mic, otherwise we don't pick it up.
Sorry. We understand why people leave. We have a very limited product set that we're allowed to produce under current law, and it doesn't actually fit the needs of most of the patients, so they do end up leaving. The problem is cannabis is a bioaccumulator plant, so if you have pesticides in the soil, if you have heavy metals, it sucks it up, it puts it in the bud, which is where the medicine's derived from. If you don't have good testing regimes within the state that you're sourcing your medicine from, oftentimes it's contaminated with all sorts of other byproducts and contaminants. That is not safe, and it's certainly not safe for immunocompromised patients, which is what is the hallmark of the TCUP program as it exists today. Ours is an incredibly well-tested program. I mean, we have to test every single batch that goes out the door.
And we're not talking about recreational, we're talking about medically necessary usage. Can you talk to me about the dose and concentration that we have available in this bill? Is it enough, or what are your thoughts on that?
And it's probably better for someone like Matt to answer that, but we have a 20 milligram dosing limit in the bill as it exists today, the HB 46. Our current program doesn't have a limitation on the amount of THC someone can have in the teacup. There's none. There's a 1% by weight limitation, as if you were regulating this like alcohol, which it's not. It's a pharmaceutical. So someone could consume 10,000 or 15,000 milligrams, over a period of time. There's no cap on that as it exists today in teacup. And we talk about some of our, more extreme patients in palliative care are consuming upwards of 100 milligrams a day. That in this bill, at least on the 20 milligram dosing cap, would not be covered. Sorry.
Is that consistent that it might need to be
I concur.
worked out per patient, or how do you address that for us if we're looking at this bill genuinely?
Looking at my patients, if we have a 20 milligram cap per dose, 10% of my patients are going to be undertreated. If you raise that to 40 to 50%, maybe 5% are going to be undertreated. I was talking to Dr. Lux. He was a gentleman that had to fly out tonight, and he's a palliative care oncologist, and we were comparing notes. Some of our severe oncology patients, and by the way, this is still low dose THC. We're treating symptoms. He and I are both using 100 to 150 milligrams per dose, which begs the question, what's low dose versus medium dose versus high dose? Being a member of the Society of Cannabis Clinicians, I get to meet with other clinicians throughout the United States. So 1 to 2 grams, so 1,000 to 2,000 milligrams are what my colleagues in other states are using to actually treat diseases, not symptoms. So I still believe that 100 to 150 milligrams is low dose.
Thank you. And Mr. Richardson, you talked about, and I heard you clearly on satellites and how you do your distribution, but tell me about the 90 days requirement.
Again, 90-day requirement, the way the TCUP works today, you get approved by a doctor. The doctor can set whatever limitation they want in terms of timing of that prescription. If they don't set a limitation, it's valid for 1 year. So most of our patients have a valid prescription for 1 year. And part of that is just a cost issue with the patients.
Thank you. Thank you, Chairman.
Okay, thank you, members.
Please help me. My situation.
Thank you for your
If you're on
testimony.
the phone, please listen to what I have to
Ma'am,
say. This is
we've
my
heard you.
life.
Ma'am,
and
we've-
I
we've
don't
heard
want
you.
to die. Texas, help me.
We've heard you, please. Thank you for your testimony.
Free the weed.
Chair calls Mark Vane, Elizabeth Miller, J.O. Mitchell, and Lucas Williams. I want to remind everyone, we We do not want to limit anyone's testimony. We want to hear from you. But it has been a long day, and we still have a lot of testimony to take, and we still have 3 bills after this bill. And so please work with us. Please be respectful to the committee, and please be respectful to the other people who are here to testify. That's all we ask. Thank you. Chair recognizes Mark Vane. Is Mark Vane among our group? Okay. We're going to show Mark Vane as registered but not testifying. Elizabeth Miller, are you?
Hello.
Okay, thank you. Elizabeth Miller, testifying on behalf of Texans Helped by Cannabis and yourself, and you are neutral on House Bill 46. Is that correct?
Yes, sir.
Thank you. Proceed.
Thank you, Mr. Chairman, Madam Vice Chair, everybody for still being here. I cannot tell you how appreciative I am to see your faces live. Truly, truly appreciative. I want to thank Representative King for this bill, or Chairman King for this bill, and everyone in this body, and that other one, for all the encouragement that everybody has given expanding TCUP. So just for the conversation, I appreciate it. It's been so much more encouraging this time, so let's maybe do it since everybody's in the mood. I'm an attorney. I'm advocate up here on civil liberties issues, but I've been doing the cannabis thing for a while, and I've had conversations with some of you before on this issue, so thanks for that. TCUP definitely needs improvement. You've heard that a lot. It needs expansion. There's a price problem and an accessibility problem, but I think improving accessibility for patients, providers, and products will help the price problem. So I think you can get there, and this will help in many ways. One thing it does that I think is really important is change the language, as you guys were kind of just getting at, from the percentage to the medicine talk. So I thank you, Representative King, for allowing us to speak in terms of medicine for a medicine program rather than drug dealer talk. So I appreciate that. The methods, the additional methods of inhalation are really important. I am one of the, I use cannabis for, I have a rare condition. It's not rare, by the way. It's the most common disease you've never heard of, called Ehlers-Danlos syndrome. And we're on the rare list, but it's not rare. And so I use it for pain, seizures. It helps, appetite is huge. I'm currently wasting away because of, it's hard to eat when you're in that much pain. So I would appreciate questions on all those, what it does better, what it could still do, please. 5 minutes. As I've explained to you, Representative Jones, I have to commit a felony in order to be here today, every day. I say that under oath on purpose, knowing because I don't have kids and I don't have employees. I have to be here to tell you I have to commit a felony to be here, and I just feel compelled to say that on behalf of everybody who can't be here.
Thank you.
Don't say that. I will call you. One of these days they're going to come for me.
Chair recognizes Lucas Williams. Is that okay? Show you as Lucas Williams, testifying on behalf of yourself, and you are neutral on House Bill 46. Is that correct?
That is correct.
Thank you.
Okay. Hi there, I'm Lucas, and I'm 12 years old. I live here in Texas, and I've been in Texas Medical Program TCUP for over a year now. I wanted to be here today with my father to show and tell everyone how much it has helped me. Before I started TCUP, I had a lot of problems with feeling really upset for no reason. I'd get really irritated and angry, unable to speak my needs. That made it hard to be around other people. I didn't want to act that way, and I couldn't just stop it. With starting this program, my outbursts happen less often and not as bad. I feel calmer. I'm more control in myself now. And it's also helped with my focus and appetite. I used to forget to eat or not feel hungry. Now I can eat better and think better too. School and everyday stuff is easier. Now I get to make friends and have fun with others. I'm still me, but I like a better version of me. I still have autism, but this program helps me do better in how I learn, stay calm, and discover who I am as a young man. And as my dad tells me, it's let me have my childhood. It makes life less stressful for me and my family. I hope other kids and adults like me can get the same help I did. I think if the program allowed more options, even more people could have a chance to be healthy and productive. Thank you for listening to my story. Please ask my father if you have questions about how this helped me.
Okay, thank you, sir. Did a great job. Chair recognizes Joa Mitchell, testifying on behalf of ATX Organics and self, and you are neutral on House Bill 46. Is that correct?
Yes, sir.
Okay.
Chairman, Mighty Vice Chair, and members of the committee, I'd like to thank you each for being here today and for giving me the opportunity to testify on HB 46. I was actually born and raised in Representative Johnson's district, and I went to school in Representative Jones's district. My name is Joelle Mitchell, and I'm a third-generation Texan that has been working in the cannabis industry for more than 4 years. While I appreciate that HB 46 would implement a much-needed expansion to the TCUP program, I fear that the bill falls short of providing Texans with what they actually need. Scrapping the THC percentage cap, increasing the number of dispensing locations, and permitting the sale of inhalable products are all steps in the right direction. The issue is that these are minor issues for major problems. My main concern with this bill is that it does not add to the list of qualifying conditions that would make someone eligible for TCUP. An easy solution to this problem would to add conditions to the list that research has shown can be treated with cannabis. These conditions include Crohn's disease, HIV/AIDS, IBS, Tourette's syndrome, TBIs, anxiety, depression, and sleep disorders. Another solution, and which I consider to be much more comprehensive, would be to allow doctors in Texas to determine on a case-by-case basis whether or not their patient needs cannabis for their condition. TCUP has certainly been a step in the right direction in terms of allowing Texans to have more access to medical cannabis. Despite the step in the right direction, the program is objectively at risk of being a total failure, and the DPS agrees with me. According to an analysis conducted by the agency, the limited number of active licenses presents a high risk to the continuity of the program. Texas is the best state in the country, and Texans deserve the best medical program in the country. Let's turn this failure of a program into a model for other states to follow. Thank you for listening to my testimony. I'm happy to answer any questions.
Okay, thank you. Members, questions of this panel? Representative Jones.
Where'd you go to school?
Linear Middle School.
Okay, yep, you're right. That's my district. I went there too. Go Purple Pups.
Go Purple Pups.
Members, other questions? Okay, thank you all for your testimony. Thank you for being here. Great job. Thank you. Chair calls Susan Hayes, Jesse Williams, Shannon Crow, and Sheldon Smitherman. Okay, Jesse Williams, is that correct?
Correct.
I thought that. Show you, I'm sorry, are you Susan Hayes? Okay.
Yes, sir.
We'll go there first. Susan Hayes, registered, you're a cannabis attorney testifying on behalf of Village Farms and self. You are for House Bill 46, is that correct?
That is correct.
Thank you. Proceed.
Thank you, and I'm going to talk really fast because I know the hour is late. I'm also the public representative on DPS's working group advising it on the TCUP program, which has been meeting for a couple of years now. And the big message I have for you today is this program is failing. It has had a boot of regulation, over-regulation on its neck since the beginning. It is not serving patients. It's not accessible. The over-regulation drives up the cost, as you heard Mr. Richardson describing this absurd system where they have to drive the product and then make it go home every night to cover a state as big as Texas. It desperately needs expansion both of the licensees and the patients who are eligible. This game of picking conditions hurts people. We should allow doctors to practice medicine, or people with some very rare, even not rare conditions like Tourette's get cut out of the program unless their doctors can fit them in sort of in another category for like PTSD. So I commend HB 46 for adding chronic pain. It would be great to also have things like palliative care. There's a laundry list of things that are left out because the legislature, not to raise a scope of practice issue, but the legislature is practicing medicine through the statute. It would also be helpful, and I'm working with Representative King's office on this, on some patient protections. You know, because I'm known as a cannabis attorney, I hear from people who have CPS show up on their door because someone at school heard they were giving their kid marijuana, and there's nothing clear in the law to not make those families go through those investigations just because they're participating in TCUP. In general, the laws we have on the books are 10 years out of date to what's happening under federal law and in the market around the country. HB 46 makes some good steps toward that, but please push it further. Thank you.
Thank you. Chair recognizes Jesse Williams, testifying on behalf of Disabled American Veterans Chapter 219 and self, and you are neutral on House Bill 46. Is that correct?
That is correct.
Thank you. Proceed.
So I want to first start off with we are talking about the compassionate use program, and this has been pushed back so late into the legislature that it's not rather compassionate. I say, give it up to my son for being here. I've been telling everybody, this kid's a trooper tonight for being here this late. But that's the lack of compassion, but he chopped it out because he understood this is how you make history, this is how you get things done in the legislature. Something I want to clear up that I've heard this evening, we talked about driving stuff out to like El Paso. And from my understanding right now, you have to order more than $200 worth of product before they're even going to bring out to El Paso. They only come out once a week. And I know this because I work with the Texas Cannabis Collective, and one of my board members lives out in El Paso and was informing me tonight. I asked him, I was like, what is the frequency for this? Because I know other places, sometimes, as Piper and Dean mentioned, it could be twice a week. For El Paso, we're talking about a town that if you're in Kerrville, Texas, the next spot it tells you to go to is El Paso. It's 500 miles. So it's this massive drive. And as we know, satellite location doesn't exactly fix that. I'm blessed that I live right behind where compassionate cultivation is at currently. I literally live in Southwest Austin, so this is something I had to listen to other people talk about how they don't have access while it's right in my back door. Something I noticed that wasn't in this bill was about research. And y'all heard me earlier this evening talking about I'm post-transplant patient, and a big thing is that the medications I'm on, my anti-rejection meds, I cannot take cannabis products at the moment. And Dr. Brinberry is my doctor. I'm part of his PTSD program when they added veterans in. And I stay in touch with him about what the medication I'm on, the things that I'm taking, and we're trying to work about how we will actually be in contact with my transplant team to possibly work with this, or even in Texas gets it together, I could do my transplant team here. I mean, we have Baylor University, one of the top medical schools, but it seems like we're almost non-competitive with University of Wisconsin that did my transplant. And earlier it was mentioned about 3 licenses. I like the idea we have 11, but we need to have a time frame at which DPS will do this 11, because the only reason there are 3 is because we initially put down we wanted to do this program, and for the whole, between 2 sessions, 0 were issued. The legislature had to come back and say, you must issue at least 3 licenses by a specific date and force the hand to DPS. And currently the language does not have anything in it that I know of from what I've seen that would tell them when they have to issue these licenses. And as a patient myself and being with him, if you any questions about that, there's other stuff I can help address.
Thank you for your testimony. Members, any questions of these two? Okay, thank you.
Thank you, Mr. Chairman.
So we had 2 that didn't show. Okay, Shannon Crow. Okay, we're going to show Shannon Crow registered but not testifying. And Shelton Smitherman. We're going to show Shelton Smitherman registered but not testifying. Okay, that one is testified. Okay. Chair calls Nick Mortellaro, Sarah Todd, Is Nick Mortellaro here? Okay, we're going to show Nick registered but not testifying. Sarah Todd. Is Sarah Todd here? We're going to show Sarah registered but not testifying. Chase Bearden. We're going to show Chase registered but not testifying. Brian Dombrowski. Going to show Brian registered but not testifying. Mitch Fuller. Show Mitch registered but not testifying. Ben Uhus. All right.
There's one.
Okay, we show you registered as Ben Uhus.
Yeah. That's close
testifying on behalf of self, and you are testifying against House Bill 46. Is that correct?
That's correct.
Thank you. Proceed.
My name is Ben Oyes, and I'm a born and raised Texan, and I come from a medical family. I completed my graduate program in Haifa, Israel, in a lab that's one of the only institutes in the world with access to studying cannabis on chronic disease and cancer models. And since then, I've had the pleasure to make the claim that I'm one of the only Americans worldwide that has seen firsthand and led research studies over the effects of cannabis on disease and cancer models. I commend the bill for allowing an incremental change in the total THC allowed per dosage and per packaging, and I thank Representative Ken King for his work. But there are a few limitations that need to be addressed, such as the expansion of patient conditions eligible, and the final decisions for concentration, dosage, and route of administration being decided by the patient's physician. Israel's program is framed by a tightly collaborative regulatory structure which allows clinical studies between labs, cultivators, and their healthcare system. Physicians closely monitor patients and are educated in the activity of the systems that it affects, including but not exclusive to the endocannabinoid system. Clinical validation and academic research are married alongside cultivators inside of the area, and as such, there's been substantial clinical evidence on the content and efficacy. A greater variety of options and flexibility for products that offer these high concentrations is necessary for patient success. While its effects are still not fully understood and why we are not certain which combinations of compounds are necessary to drive the most maximally efficacious results, we do know that full spectrum extracts and high THC chemovars are necessary to deliver the best possible results for certain conditions. An incremental change, but best practice, would be to tear down limits, remove red tape from research, and allow judgment calls on concentration to be backed by data. And I thank you for your time and welcome any questions.
Thank you. Members, any questions? Thank you for your testimony. Chair calls Jonathan Parker. Show Jonathan registered but not testifying. Chair calls Dr. Robert Marks. Show Dr. Robert Marks registered but not testifying. Chair calls Kevin Hell. Kevin. I show you registered as Kevin Hell, Legislative Coordinator, testifying on behalf of the Libertarian Party of Texas and yourself. Excuse me. And you are for House Bill 46. Is that correct?
That is correct.
Thank you. Please proceed.
I'd like to dedicate my testimony to the people that had to leave via attrition. Thank you.
Thank you. Yeah, really. Okay. Is there anyone else who wishes to testify on, for, or against House Bill 46? If not, Chair recognizes Chairman King to close on the bill.
Thank you, Mr. Chairman, members. The bill doesn't go far enough for some. It doesn't, but it is a step in the right direction if we're going to keep TCUP, and I think it's necessary. As far as adding other conditions, I'm open to those things if you got changes. You know, Chairman Frank and I have talked a lot about this, and I know there's some interest on the committee. I will say this, one thing that's not specifically talked about in here is hospice care. And I'm telling you right now, y'all have heard me over the years talk a lot about my mother. And I watched her die over 10 and a half weeks in hospice. And if I had it to do over again, instead of giving her the poison they were shoving down her, I'd have gone to Colorado and bought a joint. That's just me. I don't use it myself, but I hope for your favorable consideration on this bill. And if you have suggestions, I'm open to them, and I close.
Okay, thank you, Chairman King. Chair withdraws committee substitute. If there's no objection, House Bill 46 will be left pending. Is there objection? Chair hears none. House Bill 46 is left pending.